So very briefly about the Health and You Community Wellness Series. The overall objective of the series is to try and raise community awareness about health and disease, to try to enhance self-care, reduce suffering, improve the quality of health, and try to increase healthy longevity. Please note that the Health and You Community Wellness Series is not a CME CPD activity, so there are not going to be any certificates of participation being issued. The target audience for the Health and You series is the general public. A few housekeeping rules before we begin. Please note that your cameras and microphones have been switched off. If you have any questions or comments you'd like to address to the speaker or to the group, you can use the Q&A feature, or alternatively, you can use the chat option. All questions and comments will be addressed at the end of the session, so I will be moderating the session and I will be posing the questions to our speaker. And once again, just to reiterate, this is not a CME CPD activity, and therefore no certificates of attendance will be issued. So a little bit about today's speaker. It gives me great pleasure to introduce Dr. Rana Emam. She is an older adult psychiatrist working here at Hamad Medical Corporation. Dr. Emam is a board-certified psychiatrist specializing in geriatric mental health and healthy aging. She is an assistant professor of clinical psychiatry at Weill Cornell Medicine-Qatar and an associate consultant in older adult psychiatry at HMC in Doha. She's a graduate of Weill Cornell Medicine-Qatar, having earned her MD in 2013 and completed her residency training at New York Presbyterian Hospital and HMC, followed by a fellowship in older adult psychiatry at HMC. She holds an Arab board psychiatry and is a member of the Royal College of Psychiatrists. Dr. Emam emphasizes multidisciplinary, culturally sensitive care for older adults with mental health challenges. She teaches medical students and psychiatry trainees at HMC and Weill Cornell Medicine-Qatar, and has been a prominent lecturer in geriatrics-focused continuing medical education. She has also served as a curriculum coordinator and contributed to several educational and quality committees. Her research focus is on mental health across the lifespan, including premenstrual mood disorders, postpartum depression, and the well-being of older adults. Dr. Emam integrates a culturally attuned, lifespan-oriented approach into both her clinical practice and her academic work. Dr. Emam, we are so honored to have you here, and the floor is yours.
Okay. So as Dr. Ahmed introduced me, so I work for older patients mostly, or I manage older patients, but in different settings. So between patients who are admitted medically or under surgical teams to managing patients in clinics to visiting them at home. And it was very interesting to see that in the different settings, there was a common theme or a common question that was being asked, which is in relation to the physical symptoms and how they interact with the mind. And sometimes, even if those physical symptoms are what is called genuine, or how can we manage them to sort of relieve the suffering? And this question was not just by patients, but also by family members and sometimes even by care providers. So I felt that it was a common theme and it was important to address. So I have no financial interests related to the topic, but I would want to pay a tribute to one of my patients who recently passed away, Allah yarhamha, last month, who was struggling really with somatic symptom disorder for years and not able to get the proper support from her loved ones and family, mostly because of lack of understanding of what this means. And the common theme that they felt that it was just in her head. And though even after she was diagnosed with a cancer, they really struggled with grasping all the education around it. So I felt further that this needs addressing, and myths about the disputed. So, can we start the poll? How many of us here in the room have had one physical symptom or the other that they could not find an explanation for? Do I need to shift any screens, or can we play the poll?
I see 48% said yes, 24% said no, and 28% said maybe.
Okay. So I was wondering if some may even ask in the chat, well, are you asking about the past month? Because it is pretty common. It is pretty common for us to experience it. And if you're asking about a lifespan, we've probably had this experience multiple times. And when you, the challenge here is when you have a symptom that you know, so you exercised in the gym and you went home and you feel that your muscles are sore, you know that, okay, this is because of that. I'm going to drink fluids, I'm going to rest, and then it will go away. But you can only imagine if you don't know what this symptom is caused by, how long it's going to last. Is it going to get worse? Are other symptoms going to show up? Then it becomes really debilitating as opposed to the usual leg cramp that you are going to go about your day not worried about. So this is really what we're talking about today. What we are not talking about today is something like malingering, although it goes under like the main chapter umbrella around those symptoms or that are not explained by physical finding. But in what's called malingering, there is a clear reason that someone is intentionally coming up with a symptom. So it has two things that are not found in the other somatic symptoms. The person actually knows that they are not sick, and they are making up symptoms, like they're, for example, putting their thermometer in something hot to make it look like it's like they have a fever. And they have a reason to do that that is very clear, a secondary reason, like they want to skip work or they want to get financial compensation. And this is not what we're talking about today. What we're talking about is more of how to support you and your loved one with a symptom that you are struggling with, you don't know the parameters of, you cannot explain, you cannot control. Okay. And really affecting your day-to-day life. So let's going back in history, and really somatic symptoms have a lot of stories in history. But let's talk about the sick role specifically. And we have Mr. Parsons here. He was a sociologist, and he was a functional sociologist. So he was really interested in how the society was built and how it maintained the interaction of different members of the society, maintained sort of stability. He also studied a lot of psychology, and he was influenced by psychoanalysts like Freud. He described being ill as almost a role. It's not just like having a condition. And therefore, there were proper behaviors that you needed to go through or perform as someone who is sick. So he described that, okay, you are exempted from some obligations that you usually have. You are not to be blamed or have responsibility for being sick. Okay. But then he also described it as an undesirable state. So you should be working on remedying it and overcoming it as soon as possible. Now that, if you can think of several examples right now, has been refuted with the advent of medicine and with the aging of the population, because I don't know how much statistics you've followed, but as of 2020, those who are 60 and above exceeded those who are 5 and below. And we are having a constantly aging population globally, not just in Qatar. And mashallah, even the life expectancy in Qatar and other countries are increasing. So with that, we have a lot of people with chronic illnesses. And we have a lot of illnesses that are also requiring what's called palliative care. So these are people who are not going to stop getting sick, but we need to help them with their struggles and with their functionality. And it also imposed on you that you needed to cooperate with the physician and give the physician sort of a paternalistic role. They tell you to do something and you need to do it, which has also been challenged. But you can see how that has come up with a lot of stigma and a lot of stereotypes. A lot of experiences are described on YouTube. This is one of them. And looking at the time, I'd rather see if we have time at the end, we would play the video. But I encourage you to listen to different experiences that have gone through. This one in particular had actual anxiety that no one had the courage to speak to her about or to refer her to a psychiatrist because everyone was worried that would mean they're dismissing her. And she ended up with a year of a lot of struggles with symptoms that she was experiencing, only to find out at the end she had anxiety that was treatable and she went back to her daily life. But why go through all these struggles? So let's talk about some of the mechanisms related to somatic symptoms. Right? So the body produces physical symptoms, as we commonly know, and the psychology or the mind produces emotional symptoms. However, they interplay all the time. So you can have physical symptoms that give you emotional symptoms, and then you can have stress that is ongoing for a long time that gives you physical symptoms. And it's very common for us to talk about, oh, I'm worried about her getting very stressed, that her sugar levels are going to go up, right? Or that her blood pressure is going to go up. So we know about this intrinsically, we know that they affect each other. But also on deeper mechanisms, we know that even hormonally within our bodies, having things like chronic stress causes what would usually be like a quick reaction within your body with cortisol levels going up to sort of control inflammation level within your body. Throughout a long time, if you have stress, then you're going to have what's called cortisol resistance. So your body's response to inflammation and to danger is not the same. And what that leads to, different things, but inclusive of having sleep disturbance, having emotional difficulties like depression, and having increased sensitivity to pain and inability to control it as you would otherwise do. And my cherished Kibar al-Qadr, all the elders or our senior clients, they have a whole slew of mechanisms specific to them that happens with aging that actually, even without them complaining, causes more sensitivity to pain. So we know this is at baseline without any diagnosis of somatic symptom. They have less pain fibers in their bodies. And what that means is that although you know that sometimes they may get hurt and they wouldn't feel it, so they detect pain less, but once they feel the pain, they actually have lower pain tolerance because of a mechanism that's called CNS sensitization. So because of changes both in the central nervous system, so the brain and spinal cord, and the peripheral nervous system, you have less. You usually start with the pain high and it goes low, right? That's what we tell our children when they hit their knees. But in them, you have less of that inhibition. And therefore, you see a lot of escalation of the treatment regimen, or you have medicine after medicine changed until they start having treatment with things like opiates or opioids. And that comes with its own risks, right? So, sorry. The good news here is that there are some medications that we can give them that can help them with this difficulty, like a group of medication called serotonin or epinephrine reuptake inhibitors, or SNRIs. You've probably heard some names of them, like duloxetine and venlafaxine. Duloxetine goes usually by the term Cymbalta. This is not advertised, but these are common medications that you're hearing day-to-day in different clinics, general clinics and also pain clinics. So they help with desensitization and help you use less pain medications otherwise and get the pain under control. Then, and they are of course prescribed by the physician when they see the need for it. Then also the fear of fall, because a lot of people come with concerns. Oh, my father or mother are constantly worried about their falls, and they attribute that to probably a mental health difficulty. Well, there are also physiological and or pathophysiological causes in that sense that actually puts them at higher risk of fall. So they have less sensitivity in their joints because of common problems like osteoarthritis, something they go to the rheumatologist for. They have less vibration sense, and that goes even before the pain sensation goes and before the light touch becomes less. And they are well established to be age related. So they have less balance, less coordination, and the speed of motor responses is less. Other reasons are that the motor, like the nerves for the movement and the muscles are less. So all in all, contribute to actual increased risk of falls. Now, you would think also of them having more medicines that they are taking and more likelihood of them having other medical illnesses that also increases the risk of falls. But they can also, it's important not to ignore them. Falls are a serious risk for older patients when they actually happen, and we try to decrease that risk. So, but if you're worried that your elder has significant fear of fall, please do take them to their general practitioner, their geriatricians, and even if need be to their geriatric psychiatrist, because it can increase to a pathological level or an illness level in things like dementia. Now, you'll notice in the illnesses that we discuss or the disorders that we discuss, every one of them has a highlight, but they are not necessarily concerned with whether you have a genuine illness. You can have a genuine illness that is giving you symptoms, but it's usually the concern about how much you're affected by it, how much mental distress or your functionality being affected. So this is a figure on the prevalence of it that is from a study done here in Qatar in 2010. At that time, even the names or how they diagnosed those illnesses differed. But at that time, they noticed that about a quarter of those who went to the primary healthcare centers had one or the other of these disorders or screened positive for them. We know that we need to go through further testing to actually confirm, but they had features of them. And it's interesting that here men and women were very comparable. Usually women get a higher share of, a higher percentage of these challenges. So the first of them is what's called somatic symptom disorder. And I put the criteria in, although they're a mouthful, because I am someone who really likes details, even if something not related to my specialty. But it's basically having, the highlight of this is that you're concerned about a symptom. And a symptom is like a complaint. So I am concerned, for example, about pain or about fatigue. It's something that I am worried about. Why am I still having this? Why am I having it? And you're constantly thinking about it and how serious it could be. You're very worried about it. You're spending a lot of time, a lot of energy, looking it up, going to doctors, etc., to find out how to resolve the symptom. So what you're worried about is the symptom and how to get rid of the symptom itself or what it would mean. And it would usually take a lot of time. We start diagnosing it after it's been some months. It's usually lasting for at least 6 months. And you can have more than one symptom going on at the same time. And at least one of them would be persisting throughout that time. And the rates depend on where you're testing them. But it can be anywhere from 1 in 6 or 1 in 5 people having it to 1 in 20 people having it. And of course, it depends if you're testing in the general population or in a medical setting. We know that it's also common in children, but the features of it are different. So in children, they're complaining more of usually like a single thing, and it's usually something like abdominal pain or some other like nausea, something related to digestion, maybe a little headache. In older patients, it tends to be pain, and it's in my knees, it's in my belly, it's in my head, it's in different places, and it gets until like 65 years, and then it starts declining. So the number of people who have it start to be less, although they are with physical illness. So again, this goes against that these symptoms are not because of a genuine illness, or that they don't have a genuine illness. They can have a genuine illness. We're just concerned with how they're distressed about the symptoms. Some of the risk factors. So risk factors is basically who are more likely to get it, or what things put you at risk of getting it. So if you are an anxious person by trait, so some people are always worried about the worst happening, something we call neuroticism, they are at higher risk of getting it. About 50% of people who have somatic symptoms also have another mental illness or challenge. Usually it's anxiety or depression. And of course, this is worsening the symptoms for them. It's affecting their quality of life. It has to do with the years of education, the socioeconomic status, experiencing a stressful life event, having something in the childhood that's usually very negative, or having chronic illness, either in the patient, him or herself, or in their families. However, this is not to dismiss some people who are having some somatic symptoms that are not explained, and I'll talk about that in a minute. But why are we diagnosing it? You keep saying, Dr. Rana, that they can have a medical disorder. Why do we need to diagnose also somatic symptom disorder? It's because this preoccupation with the symptoms a lot of the time leads to a lot of invasive studies. There is a lot of pressure to do more and more and more studies. But actually, the more studies you do and the more invasive studies you do, not only does it harm you, but it actually worsens the somatic symptoms and the worries about the symptoms than they actually are. And it worsens the functionality. Then you're also missing the opportunity for detecting potential psychological distress and relieving that stress and getting the help that you need. And then that if you have an anxiety or a depression, away even from the somatic disorder, then you're not treating that, it can delay the recovery and the management of the medical problem that you have, even if it's something as simple as hypertension or diabetes or heart disease. So you would want, the ultimate goal is that you would want to recover, and recover is like not just in the distress by the symptoms, but also the functionality and doing the things that you want to do. And then, of course, having healthier aging, it also can interfere if you're not addressing it. It can interfere with in your interpersonal relationships. It can interfere with your work, your job. It can even be associated with things like suicidality. And again, the figures differ. And these do not only apply, the slide and the one before it, do not only apply to this specific type of somatic disorder, but the other ones as well. So it can be up to the level of suicidality. So depending on which disorder you're talking about, where you're getting your statistics, but the lowest figure I've seen is 5%. So 1 in 20 would have the idea of harming themselves or killing themselves, which is very serious, which is something that we need to screen for and manage. But ultimately, it's never to dismiss someone's suffering or to tell them that this is all in your head, or to ignore a symptom without actually investigating it and following it and monitoring it. Okay. And it's important to note that if someone has both a depression or another mental difficulty and somatic symptom disorder, both of them are diagnosed. So we tell them you have both, and we start managing both. And we'll talk later about the management. And again, if you have a symptom that the doctors are working on finding out, they haven't found out a reason yet, that is not in of itself a reason to diagnose someone with somatic disorder, because a lot of illnesses we didn't know about before, and then we later on found out what the cause was. Something like gastric ulcer, for example, not until later on that we discovered there is an organism called H. pylori. So it's not a cause, it's the preoccupation and the time and the energy and the stress and everything around the symptom and the functionality because of it. So I'm repeating it because it's important. And also we have, as of now, we still have things that are called like fever of unknown origin, and we keep investigating it. That doesn't necessarily mean that we're going to do a lot of invasive, and invasive is like going through your body and poking and prodding and doing very extensive investigations. But it could be as simple as, okay, so we're going to keep monitoring a check on and check it and see if it's becoming more or less than what's affecting it, and so on. Things that are common, like irritable bowel syndrome, there's also called fibromyalgia. They are not under the somatic symptom disorder. This is also important because they usually don't meet the criteria of the excessive worry about it being very serious, okay? Or the excessive time and energy, and therefore it wouldn't be under somatic symptom disorder. We start concern, thinking about it. If we're giving painkillers, they're not working as they should be. There is also a history of a mental disorder. It's very unclear what brings up the symptom, what takes it away. It's continuous, irrespective of anything that's being done. And then the noted stress and the affectivity around it, right? And it's after ensuring that there's proper education about symptoms and about illnesses, after ensuring that there's adherence to recommendation and so on and so forth. So it's important, if you are struggling with this, or if your loved one is struggling with this, to make sure that you're keeping like a diary of the symptoms, where they are, the severity, the duration, etc., that your doctor is going to ask you about, how you're thinking about it, how you're feeling about it, how you're behaving towards it. Now, the second thing we're talking about today is illness anxiety. Now, the first, I was concerned about a particular symptom. This one, I'm concerned about a particular illness. I think I have, God forbid, cancer, or I think I have multiple sclerosis, and I'm reading about multiple sclerosis the whole day. But it could be with symptoms that I'm experiencing, it may not be. And I could be behaving towards it in a very different way. So I could be seeking a lot of medical attention, or I could be avoiding completely getting investigated for it. So it could be even if I have a risk factor, because some people say, okay, I have a lot of people in my family with breast cancer, let's say, God forbid, but they could even at the same time be avoiding the regular screening for that cancer. Then it's more likely an illness anxiety, or that they're worried more than their doctors who are checking on them can tell them, like, I checked you, I'm telling you right now you don't have it. They're still worried about it. And it's been present for the past 6 months. And again, it's not in this one, it's not explained by another mental disorder. It's not just because I'm anxious about everything, I'm anxious about this too. Or I already have a general anxiety disorder. It's not explained by that on it in of itself. But again, you could have another separate anxiety disorder, but it's not part of it. It happens in, again, between 1 in 5 if you're in a specialty clinic, or in a general clinic, it's like 1 in 10. This one is mainly in adults. So children are very unlikely to come tell you, I'm worried I have cancer. And again, this one declines in old age. Most of these illnesses, if not all of them, can last for a particular period and go away. But again, it can be 6 months or more, and with significant functionality problems there. So we want to address them and treat them. And again, 2 out of 3 of those who have it have another diagnosable mental illness. And a quarter of them have an anxiety disorder. So it's a real missed opportunity. Even if we don't know like the neurobiology of what's happening inside of, or if we have hypotheses or nothing fixed, we still would want to treat the actual disorder. And we are working towards learning about it. Again, history of serious illness, serious abuse, serious illness, even in your parents, a death of a parent. So you've really seen the serious consequences of illness, or had like a very serious event in your life, can put you at high risk of it. And again, it's no longer a rule out diagnosis. It's not like, oh, I found that they have this illness, so they definitely don't have illness anxiety. They can have both. Then conversion. This one has been very attractive to the media and to a lot of history books. Before, and we brought the name of Freud at the beginning, he used to talk about hysteria. So he used to think that those with a sudden seizure-like presentation are mostly like, because they tend to be conversion like the others tend to be more prevalent in women, it's because of a migrating uterus. So he called it hysteria. Then we realized that's not really the cause. Then it's called conversion disorder. And then now in the most recent diagnostic book, it's called functional neurological symptom disorder. So this one, it's a particular symptom that they're exhibiting, and it's specifically a motor. So something has to do with movement, or a sensory. It's usually something in the neurons or nerve related or neurology related. And it's usually happening, brought on suddenly, and it's usually happening after a stressor. Okay, so someone all of a sudden became mute. And it's not, the symptom per se is not explained by another medical or mental disorder. It's not part of that. So we know that people, for example, who get a stroke can become mute. So that wouldn't be a conversion disorder. But they can happen alongside another mental disorder, whether it was diagnosed before or will diagnose it for the first time. And it may or may not cause actually here distress, but it's definitely causing functional impairment. As in they're not doing what they usually like to do or did. And it is happening also here. 66% of adults is almost like 1 in 20. It's usually more in women. And interestingly, if someone had, for example, a seizure disorder, they are at a higher risk of having a conversion or a functional neurological symptom disorder. So an episode of what looks like a seizure, but it's not actually a seizure. And then we still need to diagnose it, because if I take it as an actual seizure and this person is taking his or her anti-epileptics, but they're still getting seizures, I'm going to keep increasing the dose. And with that, I'm getting more side effects. I'm putting the patient at risk. So that's part of why I need to tell if this person is having it genuinely, like this is an organic episode or a functional episode. And again, they are not making it up. If you put them in a functional MRI, you will see that the activities of their brains are different. It's not the electric impulses that are happening in a seizure episode that usually would get with like an EEG that's measuring the seizure activity in the brain. That's not usually it. But it's a difference of the brain's behaving, of the neurotransmitters in the brain behaving during that episode. But again, it's something that is treatable with treating the psychological distress and with therapy and the other modalities that we're going to be talking about. Now, I'm not sure if you're counting with me, but I believe this is number 4, which is psychological factors affecting other medical conditions. What does that mean? So it's not necessarily a constellation of depression or anxiety. It could be as simple as, I was watching, I'm sorry about this negative connection, because we're watching all the soccer games or football games these days. But then all of a sudden, I have like a sudden surge of like, go, and then heart attack, God forbid. So that this emotion that could be either very acute, very intense, or it could be something that is persistent and chronic, and then it would affect whatever medical condition or cause whatever medical condition. So there has to be a close temporal, which is like time related between the psychological factor and the actual either new illness or something that worsened, okay, or something that is not recovered as it should be, as quickly as it should be, or that that is interfering with the treatment of the medical condition. Someone is completely like blah attitude towards taking his or her insulin. I remember the first case I saw as a medical student, at least one of the first cases, was an adolescent who simply had misunderstandings around what it meant to be diagnosed with diabetes. She thought that that means that خلاص, I'm going to get my foot amputated, I'm not going to go to college. And that led to a cycle of being totally ambivalent about taking her medications, although she did go to appointments. And then eventually that led to a depression. But at the beginning, it was simply those feelings towards the diagnosis, part of which contributed to by her not really grasping what it meant at that age. And then, of course, it causes health risks, and it can influence even the underlying like physiology. So it's not necessarily what usually happens with a panic disorder or something else, because in panic you would have physiological responses, but this is different. This is really because of something related to how you perceive the illness and how that influenced how the illness happened, like how the illness progressed. We have like famous things like broken heart syndrome, which can affect the heart muscle with some sudden emotional stress. And it can be something like chronic, as I mentioned, like chronically being stressed and burnt out at work, and how that influences hypertension. This is, I'm just mentioning because I remember that I promised to mention this variance in presentations. So I said I will not talk about malingering. They know they are making the symptoms and they know what they want out of it. In factitious disorder, they can be making the symptoms, but they don't know why. It could be as simple as they are really enjoying the care and attention and support that they are receiving in the medical settings, but they are creating the symptoms. And these are much easier spot out with simple observation when they are observed versus when they think that they are not observed. Okay. And it could be anywhere from the thermometer example I mentioned, or someone can be doing something much more severe. And it's important in those cases to prevent them from harming themselves, because they are harmful to themselves. And it's not for any external reward. It can be damaging all the way to being by proxy. So it's when they also, for unknown reasons to themselves, but harm someone else. It could be their child or their elder, or anyone that they're dependent on, and they bring that person. And it's anywhere from as simple as, oh, my child has a learning disability, when the child is clearly okay, to injecting them something that can affect their temperatures or their or something else that's more grave. And in those situations, of course, social work and protective services are involved. So this is just to mention something that is in between all the somatic symptoms that I've mentioned and all the way the malingering that I will also not be talking about much today. The final one I'll touch upon today, and this is to just emphasize how much mental and physical work together and are important to address jointly at the same time, and avoid any stigma around that. They are ingrained in our biology. So you can have something called mental disorder due to another medical condition, or due to a medication or something. So you can have a depression due to a cancer, for example. The timeline, the physiology, everything adds up. And in those situations, it's not like the psychological factors. It's because, like, in psychological factors, oh, I am feeling this way about my illness, or I think this way about my illness, so I'm not doing 1, 2, 3, for example. In this one, it's a direct biology without any interference from them, and they also need to get treated for it. some other examples. They can be of shorter periods. We have variances of shorter periods than the ones earlier, but there is something called, for example, pseudocyesis, just because it's interesting, where people can literally have all the symptoms of pregnancy. Oh, I'm feeling like the body temperature rises, the fullness, the nausea, and then they wouldn't be pregnant. And it's also related to psychological factors. So how can you support as family and friends? So just being aware of everything that I talked about before and caring enough to show up for this in an evening of a workday is showing great dedication on your behalf. So kudos to you, mashallah. But also awareness of how them, while experiencing all these symptoms and being distressed by it, also being socially isolated, or being told that it's all in their heads, or being told that, oh, they're not doing enough, or they could fix it if they want to, is very isolating, and contributing to depression is very important. So let's avoid the judgment. There are most likely genuinely distressed by those symptoms. The other ones are very easy to fish out. So if they are experiencing those symptoms and they're very distressed by them, having them socially integrated, so you're still okay, let's go watch a movie, or let's go shop together. If you're afraid, I'll come with you type of support is very, very useful. Okay, the intergenerational relations, simply because I work with older adults, bringing your grandchildren, their grandchildren, is very useful. It helps break the isolation, help even with managing depression or preventing depression. So a second thing is, please help them avoid the stigma of mental health. We've already talked about how both mental and physical interplay, even on a very deep biological, neurobiological level. So please encourage them to seek mental health support as advised, and validate their experience. Help them take small steps towards recovery. Like, ask them, like, can we challenge ourselves, or can we try to take small steps? Let's see if it works. Maybe it will work. Type of steps. Support them with the education, because sometimes if I'm very distressed about my illness, I cannot hear everything the doctor is saying. And then offer them support with functionality, as we said. As professionals, what we usually do, and I'll try to wrap this up quick, but we usually function on many different levels. So we see the social level. If there is a clear social problem that we can help or involve a social worker, we do. Then in terms of, we are aware of faith and spirituality, and we usually refer patients back to their accredited departments that can help support them from a religious point of view. We know that the Ministry of Endowment, for example, can have certified members that can educate the public about how to cope with physical illness or physical symptoms. Then psychology, we know that a lot of therapy modalities can really help. And those who will ask the question about hypnosis, yes, it does help with especially conversion disorder, but other therapeutic modalities or therapies like cognitive behavioral therapy, psychodynamics, for the different ones. If you've heard the terminology, well and good. If not, I think that warrants another talk. But they are all administered by psychologists. Hypnosis, I'm not sure here in Qatar, but the other ones are definitely administered. A biological dimension, as I mentioned, there are medications. If you are diagnosed with a mental illness, or there are different medicines offered by psychiatry, and even can be at the GP primary healthcare level, as well as treating any underlying medical cause. Other things that the doctors may do to help is to try to schedule regular visits, to follow the symptoms for you and support you throughout. And they are validating your symptoms. They will put goals of treatment so that you can progressively function more, be activated more. And they will see when they need to actually refer you to other specialists, be it psychiatrists or others, for functional the disorder itself with the motor symptoms or the movements. They can refer you to physical therapists or occupational therapists for exercises graded. They will educate you about the disorder. They will see if there are any adherence problems to medication, how they can work with you to manage them. But they will also limit diagnostic tests to those indicated. They were always prioritizing avoiding harm. And it doesn't help if I, with my medical knowledge, just follow anything that you've read on Google, because I know that 1, 2, 3, and 4 can really harm more than benefit in your case. So this rapport and this alliance and finding people who you trust is very key in this management. They will have to ensure that the serious medical illnesses are actually ruled out by the ways they're indicated in common medicine. And they will again explain to you the process of disease, how psychological, social can contribute, and they will educate you on how to cope with the different symptoms that you have. They will advise you to treat the common psychiatric disorder and refer you accordingly. If you're taking unnecessary medication, especially the more harmful or addictive ones, they will help you slowly withdraw them or take them away. And again, they will ask you more about any triggers and refer to psychiatry as needed. Do not dismiss any symptom treatment. Do not take them advising you to do exercise as dismissing your illness, because we know that exercise on a deeper biological level actually leads to better pain control. We know that assessing and managing things like sleep eventually lead to also better pain control from a biological stance. So it's not about whether you have an illness or not. It's about supporting relieve your suffering and helping you cope and function and age healthy. And the answer is not more invasive testing. It's in having a trusted team that you know is advocating for you and following with them and building an alliance with them and not letting stigma stop you, and keep it up. So let's accept that not everything we know, but inshallah we'll know them in the future. Thank you for listening.
Thank you so much for that very important introduction. I think, Dr. Rana, on a topic that there's perhaps limited awareness of, not just amongst the general public, but I think even healthcare professionals. So it was a wonderful talk on a very, very important topic. So thank you. Just as a reminder to our attendees, if you have any questions or comments you want to address to Dr. Rana, please put them in the chat or the Q&A, and then we can ask them to her. But I'll start off with a question of my own while I give everyone a minute or two to put their comments in the chat. As you touched on, there might be some stigma that is associated with these kinds of illnesses or disorders. So how do you go about initiating a conversation with someone who might be living with this disease or disorder, or you suspect of living with this disorder in a non-stigmatizing fashion?
Sure. So I think I am trying to use some of these techniques even in my clinics. And that's part of how we ended up building some of our clinics, even in primary healthcare centers, so integrated with everything else, as opposed to the isolated mental health hospital that we had historically. And it's starting off with asking about the symptoms, as you would in your regular practice. How did they start? And then giving a comment about how stress itself can sort of trigger something, and especially the example that is similar to when I talked about the psychological factors affecting other medical conditions, and people being aware of things like, oh, stress can worsen people's high blood pressure. So I talk about that, and then they start mentioning some stressors, and then you empathize with the stressors that they've had and ask, well, how has that affected you? And then both the patient and in my situation with older patients, there's usually a companion. And if it's a child, there's usually a companion as well. So they would pitch in also, oh, it's caused them to have this, and that. And then I would ask, well, I wonder if this symptom or this feeling of significant sadness is something that we can also work on to help you manage your symptoms. And I'm always, as I'm speaking to my patients or my clients, I'm always seeing the responses I'm getting from them, so I can see if they are really resistant to the idea, or if they are willing to hear more, and I go from there. If I find that they're completely resistant, I might talk to whoever they brought with them in clinic. So it's a work in progress, but it's always going from the physical to the psychological and explaining the transition that helps us get them on board, inshallah.
Excellent. Thank you very much for that. And in your opinion, what do you think might be the biggest barrier towards, catching this disorder or managing the disorder?
Well, it's challenging, and I think stigma is the biggest one. But it's also that you want to strike as a health professional. It's striking the balance between when are we drawing the line of invasive versus non-invasive illnesses. And this is where you involve the MDTs. So in these cases, because they tend to be the more challenging ones, that we involve the multidisciplinary team and having other opinions on board so that you are even more confident about this being the acceptable level, that I wouldn't want to do more so that I don't harm my patient more. And then you monitor your patient. Like it does require a lot more work and knowing your patient and having a close alliance with them than the general problems that wouldn't have this overlay of psychological or somatic aspect to them. And that's part of why we're called a lot of the times to help the primary teams manage them.
Excellent. Thank you. Another question would be what role do you think cultural beliefs or practices can play when working with individuals who might be living with these kinds of disorders?
Different cultures affect differently as well. Like a culture definitely plays a role. It's interesting when reading about protective factors versus unprotective factors relating to that. So there was a recent study actually done in like some 16 countries in the MENA region, and found that the younger generations actually believe, for example, religion, and specifically the Islamic religion, and this one actually promoted more approach of, okay, get treatment if need be, or get psychological treatment as need be. So there is definitely generational variance, cultural variance, educational variance, and as you see, some of them already have the risk factors being less education. So it definitely plays a role, and you being culturally attuned really helps. You should never neglect the culture or the spiritual factor when addressing them, because they're really powerful.
Excellent. Another thing you touched on, I think, was how we access medical information today online can play a role in terms of how such illnesses could be managed. I was wondering if you could elaborate on that a little bit further.
Yes. So in fact, if you see, some of the criteria include this. So before, we had probably less access to medical information, and as of now we have more access to medical information. So a lot of people are spending a lot of time, especially when it comes to like somatic symptom disorder, and looking up things. But the problem with that is that it doesn't have the usual protection of what we usually have as medical students or medical trainees, where you have someone who's putting things into perspective and actually weighing the probabilities of things. So it is good and bad. It's good because you are able to get more education if you strike the reliable resources for the public. So we do have reliable resources from health ministries, be it here or outside. So there are reliable sources of information. But if you're just reading off of different people's experiences that are not filtered through the medical lens, then you can start having more suspicion about having more illnesses, and that has a negative feedback loop for these diseases, unfortunately.
Okay, I'm not seeing any further questions in the chat, so perhaps if you can just sum up one or two key takeaways that you want people to remember from the session, and we can conclude from there.
Yes, so if I can think of two, it's support the person with the symptoms, support them to become functional again and to do the things that they value and that improves their lives. And then the second thing is help your loved one. And if you are the person struggling, please consider the psychiatric and the psychological factor. It can make a life difference to you. Thank you for listening. And
Thank you
for
so
inviting me.
much, Dr. Rana, and thank you to our attendees as well. I think that brings our webinar for today to an end, and we will see you at the next one. Take care, everybody.